desk-side briefing on the COVID pandemic response activities hosted by the Association of State and Territorial Health Officials. Today's conference is being recorded and is on the record. At this time, I'd like to turn the call over to Jim Blumenstock, Vice President of Pandemic Response and Recovery. Please go ahead, sir.
Hey, Alan, thank you so very much. And good day, everyone, and thank you for so much for joining us today. And we truly hope you and yours are well and staying safe at this point in time. It's been 5 weeks since our last media briefing, and a lot has happened in the interim. And we really welcome this opportunity to provide you with updates from the field regarding our collective pandemic response. As many of you may know, we continue to prioritize primary series vaccination for eligible individuals. In the 38 weeks of our vaccination campaign so far, we are so pleased to report that we've administered over 370 million doses of vaccine, with 174 million people being fully vaccinated. We've also achieved a significant milestone last week with the FDA awarding full approval of the Pfizer vaccine for adults. In addition, we recently recommended that those who are moderately or severely immunocompromised receive a third additional dose of the vaccine. And as of this point in time, since August 13th, 996,000 doses have been administered to that subset of our population. Lastly, we continue to make preparations for the potential for administering booster shots, according to the plan announced by the White House on August 18th, subject, of course, to the green light being provided by the FDA, the CDC, and their advisors following the requisite regulatory and scientific due diligence. Well, we're here today a couple of days before Labor Day weekend. Many are poised to enjoy the waning days of summer with travel and recreation. By next week, virtually all school districts will be back in session, striving to provide a safe and rewarding in-class experience for our children. And at the same time, we are working so hard to mitigate the COVID-related impacts, as it seems like our nation's entire country is in an emergency response mode at this time, resulting from the wildfires out west, the devastation caused by Hurricane Ida, and in supporting the repatriation and resettlement of those arriving from Afghanistan. So with this as a backdrop, and as you will soon appreciate, the main theme surfacing from today's remarks is that of prevention. Our healthcare system is being pushed to its limit and beyond, caring for those with severe COVID illness, cases which in large part could be avoided. Some facilities are running out of ICU space, experiencing shortages of critical care medicines, disrupting necessary care for non-COVID patients, and with all this taking a huge toll on our frontline heroes, the healthcare workforce. I really don't think that there's another time when Benjamin Franklin's axiom, an ounce of prevention is worth a pound of cure, is more apropos. You'll certainly hear more from our panel in a few moments with examples, and now it really is my pleasure to introduce them to you. As we have done in the past, we've assembled a small number of our 59 members across the country to share with you their experiences from their jurisdictions and really enlighten this conversation with specific examples and activities. We are so pleased to have with us 3 state health officials from geographic and demographically diverse jurisdictions. First, we will hear from Dr. Nirav Shah, who is the ASTHO President and Director of the Maine Center for Disease Control and Prevention. Dr. Shah will be followed by Dr. Zink, who is the ASTHO President-elect and the Chief Medical Officer for the state of Alaska. And finally, we'll hear from Dr. Thomas Dobbs, who is the State Health Officer for the Mississippi State Department of Health and is also the chair of ASTHO's Infectious Disease Policy Committee. Our 3 panelists will spend a few moments each giving you short prepared remarks, which will give us ample time for questions and answers and conversation. So with that, Dr. Shah, I will turn the program over to you.
Great. Thank you so much, Jim. And good morning to all of our colleagues in the media. Good morning and good afternoon to all of our colleagues in the media. We very much appreciate your joining, and we're looking forward to the conversation today. Our purposes today are twofold. The first is to sound a warning about the Delta variant's impact in public health and healthcare systems throughout the country, but also to talk about hope and the future and some positive signs that we see on the horizon. Now, although vaccination rates are increasing nationwide, hospitals, health departments, and those who staff them are at capacity. This strain on the healthcare system is being driven principally by 2 things: The first being the Delta variant, and the second, those who have chosen not to be vaccinated. Nationwide, a month ago, 5 weeks ago, at our last briefing, we were talking about hotspots. But now, with 96.6% of all counties in the United States seeing high or substantial levels of COVID transmission, we've moved beyond hotspots to a countrywide hot zone. As a result, in many places in the country, the choice is stark. Either you get a shot or you get COVID. Even in Maine, where 81.2% of the eligible population has received at least one dose, and nearly 3 out of every 4 eligible persons are fully vaccinated, we are seeing significant case growth, significant increase in hospitalizations, and sadly, even an increase in deaths. Why? How to reconcile these two seemingly opposite factors? Well, fundamentally, what we're seeing right now is a bifurcation of the pandemic, with unvaccinated individuals driving the bulk of transmission and accounting for the majority of hospitalizations, ICU admissions, and ventilator use. What else I think has changed is the way we think about COVID. Generally speaking, when we think about COVID, we often think of its direct effects rather than the indirect ones. But we're in a place now where the indirect effects of COVID are just as impactful. The ripple effects that are being caused by hospitals being packed with COVID patients are being felt across the healthcare system. These packed hospitals, for example, mean that those seeking non-COVID care are having significant access challenges. And for individuals who have cancer, heart disease, and other serious medical conditions, care delayed is care denied. Now, every lifestyle choice comes with consequences, and the choice not to get vaccinated is no different. But that choice is having a domino effect across hospitals, schools, the economy, and across society. The next phase of our response to the COVID pandemic, to say nothing of the next pandemic, will require a frame shift in how we view our relationship to one another, and a recognition that by not getting vaccinated, you are putting more than just yourself in jeopardy. Now, all of this is leading to an undercurrent of hopelessness across the country, and that's dispiriting, because now is the time where public health officials need the population to stick with us when it comes to, as Jim mentioned, a strong focus on prevention. But this hopelessness is concerning. Now, for me personally, to be straight with everybody, hopelessness in my mind is sort of the union of bad things happening and a lack of control over them. But here, despite all the gloom, we have control over things. And for me, hope starts with at least recognizing, first of all, how much worse off we'd be absent the vaccine. It also starts by recognizing that the core strategies to prevent and ultimately tamp down on COVID have not changed throughout the pandemic. As we go into the Labor Day weekend, my agency is recommending that folks wear masks, particularly if they're going to be in indoor public settings where there is high or substantial transmission. And we're redoubling efforts to make vaccines available, whether it's at a county fair or at the local doctor's office. There is hope available, and that we do have control over the situation. Where we go from here fundamentally depends on all of us. So with that, I appreciate your time. I look forward to the discussion. Jim, let me turn it back over to you.
Great. Thank you so much. So, Dr. Zink, let's turn to you.
Great. Thanks, Jim. And thanks, Dr. Shah. That's a great introduction. I, too, want to thank the press for being here, but I also want to start by thanking a couple others. First of all, I want to thank the healthcare workers. This has been a long haul, and you have been on the front lines of this in so many ways for months on end. I know it's not getting easier, it's getting harder, and it seems like it could be hopeless, and so I want to thank you. I also want to thank the public health teams who, too, have been working on the front lines of this in so many ways. Our teams that support us are unbelievable and incredibly important to being able to respond to this pandemic. And I want to thank the American people. We are all done with COVID. We all wish it was not here and this was not the case, but we must face the reality that COVID continues to spread. This is a place that I hoped we would never be at the pandemic. We have some of the highest case counts and honestly the highest hospitalizations we've seen across the country. In our hospitals in Alaska, we have limited healthcare capacity that's being stretched in a way it's never been stretched before. The combination between limited staff, increased people in the state, as well as overall COVID surging, our inability to care for both COVID and non-COVID patients is honestly heartbreaking. We don't have the ability to transfer patients like we used to. We don't have the staff to care, and everyone is being impacted by this. It is also impacting our schools. We know that children do well in in-person learning, and everything we can do to make sure that they can have a safe and healthy school year this year needs to be our top priority. However, as fall settles into Alaska, the leaves start to change and we continue to move indoors. I'm reminded that this month, which is also Recovery Month, is a month of hope. And it's a month that we're reminded of the tools that we truly have to fight this pandemic and to become more resilient as people. We have PPE for our healthcare workers. We know that masks work. We know that we have testing and availability, and we need to continue to push to make sure that rapid available testing is available to every American who wants it. And most importantly, we have truly life-saving vaccines. As Dr. Shah just mentioned, we continue to see our hospitals primarily being filled with unvaccinated, younger, and sicker patients. And I can't imagine what this would be like if we did not have the tools that we have today. So each day, we have to wake up and make a choice on how we're going to be able to work together, to put that mask on when we head into the store, to be able to keep our kids home if they're not feeling well so that we don't spread the disease to others, even if they're vaccinated, and making that decision to get vaccinated to help minimize the disease on yourself, your family, your community, and to help protect our healthcare system, which we all rely on. With that, I'll hand it back over to Jim.
Great. Dr. Zink, thank you so very much. And finally, Dr. Dobbs, we'll turn to you, sir. Dr. Dobbs?
Good morning. I'm going to springboard off the message of hope that Dr. Zink had shared, but a different kind of hope. And the hope that I have is that other states and communities can learn from the errors and mistakes that we are experiencing in Mississippi. We have seen probably, well, without a doubt, the most difficult and challenging month of the COVID pandemic, even though we have highly effective options in preventing transmission, hospitalizations, and deaths. Our hospital system is absolutely overwhelmed. We are in a perpetual negative bed status for ICU capacity. We've had to adopt many different crisis standards of care just to survive. We've had to pull down many, many millions of dollars of federal resources. We've had to open up 2 tent hospitals, and all of this in the context of a highly preventable disease because we are an under-vaccinated state. If we look at the number of deaths that we've had in Mississippi, we have recorded 838 deaths so far. And we know there are going to be many more reported because there's a bit of a lag. But within that number, there's additional information that I think helps us understand really what we're talking about. We have 2 deaths in teenagers who were generally just pretty normal, healthy kids going to school. We have 61 deaths of people 18 to 39, 83 deaths 40 to 49, and 259 deaths in the age group of 50 to 64. 100% of the deaths in those under 40 were unvaccinated. 97% of the deaths in the 40s were unvaccinated. And of those between 50 and 64, 96% were unvaccinated. There are a lot of death and personal tragedy that could have been avoided if we had done a better job making sure more of our population had been protected with a highly effective and safe vaccine. I know numbers say one thing, but anecdotes say something else. I was talking with a physician who, OBGYN yesterday, and they had 5 women die in the hospital this week. 4 of them that were pregnant. 3 of them they had to do an emergency C-section in the ICU, and the moms didn't make it, and the babies were severely premature. This is the reality that we're looking at. And again, none of these individuals were vaccinated. We have a highly effective and safe vaccine that is way underused. We're all connected in a very complicated but comprehensive web, and we know that transmission somewhere doesn't stay there, it goes everywhere. And one of our biggest challenges in the South, where we opened up the schools earlier, is we have had a ton of cases within the school setting. Last week, with only about half the schools reporting because of the hurricane disruptions, we had 23,450 kids out on quarantine. So far, since starting school, we have over 2,500 staff who've contracted COVID and 14,000 students. Not that they all contracted it in school, but around school such that it's very disruptive to the learning environment. Please remember that we're all connected, and what we do, it affects one another, and also that Delta is different and Delta is deadly. We need to use the tools available to us to prevent unnecessary personal tragedy. Thank you, and I'll give it back to you, Jim.
Great. Thank you, Dr. Dobbs, and as well Dr. Shah and Zink, for sharing, obviously, examples of some stark realities that we and all of you are facing every day, but also the options available to us with rays of hope going forward. So with that, Alan, if I could just turn to you, we'll open it up to our visitors, and they should certainly feel free to identify themselves and ask their questions. Thank you.
Thank you, sir. If you'd like to ask a question, please signal at this time by pressing *1 on your telephone keypad. If you're using a speakerphone, please make sure that your mute function is turned off to allow your signal to reach our equipment. A voice prompt on the phone line will indicate when your line is open. Please do state your name and your outlet before posing your question. So once again, that is *1 if you'd like to ask a question. And we will go to our first caller. Please go ahead. Your line is open.
Hi, this is Emma Court with Bloomberg News. Thank you for holding this call and for taking our questions. You know, I heard you guys talking about kind of how the same tools are still relevant, you know, masking, vaccination, those kinds of things. I'm hoping you might be able to speak to what strategies have changed during Delta. For instance, I heard from one epidemiologist, you know, the concern that antigen testing may not be as useful, you know, when you're testing someone who's vaccinated and may have a breakthrough infection. Can you speak a little bit to the dynamics of, you know, how public health strategies are changing during Delta, as well as knowing that, you know, some larger and growing portion of the population is vaccinated?
Thank you. Allow me to open up to our panelists.
You know, I'll just start by offering one or two notes, and then certainly Drs. Zink and Dobbs will have more to say. But you know, Delta has been sort of a variation on a theme. That is to say, the core of the strategy of containment remains the same, be it physical barriers, masking, distancing, as well as, of course, vaccination. And then on the treatment side, as Drs. Zink and Dobbs are more familiar, we have additional treatments and assists from things like monoclonal antibodies. But the core remains the same. What has changed is the urgency. Delta, by all accounts, has a shorter incubation period and has a greater force of transmission, to say nothing of being able to cause more cases within transmission events. So what's changed, at least here in Maine, is that we've turned up the dial on our activities. We've turned it up from what was already a 10 or 11 to a 15 or 16, because we know that our window in which to intervene on, say, super spreader events is that much shorter with Delta than prior variants.
Thank you, Dr. Shah.
I guess I would just add to the things that Dr. Shah mentioned. I guess I would also mention, not only do we have the Delta variant, but we're just at a different place in this pandemic as a population. We're all tired of COVID. We desperately need our kids in place. I sometimes feel like the actions we have asked the public to do, between staying apart and not seeing each other, not kind of being physically close, is like holding your breath. And you can only do it for so long. We are human, and we need connection, and we need gatherings, and we need interaction. So I think we've also moved to almost a harm reduction strategy. We have all sorts of layered tools that can be used now. It's been fantastic to see many of the schools and businesses adding layers like ventilation, being able to have rapid testing to be able to identify cases. So I think it's not only the old tools that we had before, but it is also finding ways that we can layer these tools into our everyday life that helps to keep our kids in school, our families safe, and be able to really have harm reduction, knowing we're not going to eliminate every case, but we're going to be able to do what we can to keep people out of hospitals and from dying from this disease. That's what these vaccines were intended to do, and that's what we continue to do, is to try to make sure our systems don't collapse and make sure that people have a chance to be healthy and well and not be hospitalized and not to die from this disease and others.
And I'll just add that, I agree entirely. And if we talk about one of the things that we do with case investigation and contact tracing has become that much more difficult because the outbreaks are far more extensive by the time we're aware of them. And instead of finding, a couple of contact cases to a case, we're finding, 9, 10, 20 that are spread far afield. So it just speaks to the contagiousness of the Delta variant. It's extremely challenging. But I will say that it seems like the same measures we used before are useful, and they're just that much more important. Outdoors, we're not seeing any more transmission outdoors than we did before, and it's the same sort of scenarios that we saw transmission previously, but it's just more intense.
Thank you. Next question.
All right, we'll go to our next caller. Please go ahead. Your line is open.
Hi, thank you so much for doing this call. This is Ariel Cohen with CQ Roll Call. I was hoping you all could talk a little bit about your plan for potentially rolling out COVID-19 booster shots and how much you're sort of banking on that and what you're doing to get ready. Thank you.
Hey, thank you. So, Dr. Dobbs, you want to start that off first?
Yeah, I would love to. So we've already rolled in the immunosuppressed folks into our structure. We've transitioned from the sort of drive-through model more to the normal modes of care model, which is then augmented by a couple of different things. We're using our county health departments are doing self-appointments in every state. Every county in the state of Mississippi. But additionally, we recruited many hundreds of clinics that are able to do vaccinations on site, and that's going to be huge, like we do with flu, right? It's going to be more like that. But also we have a bunch of partners that can do spot locations, sort of pop-up clinics. So we sort of built up a more sort of personalized infrastructure that I think is going to help meet the needs of the population, both in the sense of it's going to be more local and easier to access through the normal sort of healthcare routes. But additionally, we've recruited team members through this whole process that I think it's going to be a lot more seamless than we saw with the initial rollout.
Thank you. Dr. Zink.
Yeah, no, I appreciate that question. I think that states and communities have gotten good at pivoting, and we stand ready to roll out a booster shot when and if it's available. Like Dr. Dobbs, we have many more vaccine sites than the first rollout, and as a country, we have a lot more vaccines. So I think that will make the rollout a little bit more streamlined and be able to help people get vaccine where they're at. In Alaska, we have many very rural communities, and as I mentioned previously, fall is coming. So we have contingency plans depending on the weather, because that is the big factor moving into our season this year. But we're relying on the very similar infrastructure that we had before, which was just tremendous partners with our tribes and our local communities to be able to get vaccine out in their community. And we'll do the same, and just like Dr. Dobbs mentioned, have already begun that with those who are immunocompromised.
Thank you. And Dr. Shah.
Yeah, Ariel, thank you for that question. This has been a topic, as you might imagine, as state health officials gather quite frequently every week, many times during the week, to talk about where we are with COVID. One of the top issues has been boosters. So we've discussed this as a membership quite extensively, and reflecting on just what other members have shared with us as well. States are ready. They're getting ready to go back into boosters as that becomes indicated. That being said, I think I share on behalf of many other state health officials, although there is a focus on boosters, there's a simultaneous focus on primary vaccines. Basically, you can't get a booster unless you've gotten your first shots. And so there is a simultaneous focus among states in the primary series, getting those first shots into arms, as well as now ramping up and thinking through boosters.
Thank you. Next question.
All right, we'll take our next question. Caller, please go ahead. Your line is open.
Hi, thank you so much for taking my question. Max Baird here from CBS News. Staying on the booster topic, the Biden administration has held firm about their initial announcement, which was a plan for boosters for the general population 8 months after their primary series. But it's seeming increasingly likely, like advisory panels like ACIP will not recommend in such broad strokes an initial booster policy. Are you concerned that the administration's announcement and their policy that they're pushing has made it more difficult for you to communicate what the eventual booster recommendation will be sometime this month?
Yeah, Max, I can jump in here. This is Nirav. Max, as you might imagine, as I mentioned to Ariel, this has been something that we've discussed as state health officials, as we would discuss anything of such importance. Right now, I think we are waiting to see what the ultimate direction from ACIP, to say nothing of FDA, is with respect to boosters. I can't speculate on where we might go or what messaging challenges we might have based on what may happen in the future. We're really focused on the planning that will be needed, the architecture that will be needed to get boosters out. As you heard Drs. Dobbs and Zink mention, whether it's distributed models or a focus on centralized models. But in terms of the messaging, I think the tenor among state health officials has been, let's wait and see what comes out and then think through how we convey that to our residents.
Excellent, thank you. Ann or Thomas, anything to add before we move on?
I would just reiterate that we continue to pivot and we'll continue to stand by. We need to make sure that we follow the science. We're continually humbled by this virus and we continue to learn new things every day. And so I appreciate the communities and our partners and the public continuing to listen and to be able to partner with us as we learn more. So we'll just pivot as we need and as we get more information, data, and science as we move forward.
I agree.
Thank you. Great, thank you. Next question, Alan, please.
All right, we'll take our next question. Caller, please go ahead. Your line is open.
Hi, it's Dan Vergano from BuzzFeed News. I have two questions. I was wondering if the official from Mississippi or anyone really could comment in terms of lessons learned, what they would tell other places about schools opening and transmission. We still are hearing from people who say schools are perfectly safe, they should be wide open and everything like that. I mean, what warnings or what would you tell those people? The other thing is I wondered if you guys could comment, CDC released a report today finding that hospital-associated infections have gone up in the pandemic. I'm wondering if that's something you are seeing or, have any perspective on yourselves. Thanks for any help.
Thank you. Let's do the first question first. Let's open up to the panel on lessons learned regarding school reopening.
And this is Thomas. I'll kick it off. The same rules sort of apply. What we see and we have experienced is that kids in an ordered setting who are masked and separated by even a minimal distance, we don't see much outbreaks. And I think some of the CDC data released in the MMWRs shows how important that is. Unstructured settings where kids are not wearing masks, social events and that sort of thing are going to drive transmission. It's the same exact situation that we saw before, but it's just that much more intense. School can be conducted safely, but any indoor activity without masks or kids are interacting in of a more sort of like chaotic manner is not going to be conducive to limiting transmission. The other piece is it's very important to look at your scenarios and be willing to do a transition to virtual for a period of time so that things can sort of cool off. And that's kind of what we've seen. And right now in Mississippi, the majority of school districts have opted for mandatory masking because they have realized the value or have suffered through massive outbreaks and are unable to operate otherwise.
Thank you. Others?
Yeah, this is Ann Zink from Alaska. We've been in school for just over almost 3 weeks now here in the state of Alaska. Hope is incredibly important, but hope is not a strategy for opening schools. And so I would really encourage any school district who has not yet opened to learn the lessons from those of us who have opened and the fact that the mitigation tools that the CDC lines out to help minimize transmission are going to help you to stay open, are going to help keep your kids and families safe, are going to help your adults be able to stay and work and in jobs. When we look at our districts that have had universal masking in schools, have been able to add additional tools such as ventilation and distancing, kids are staying in school and they're doing well in school. But those who have opened, who are just exhausted with COVID, didn't want to have any mitigation or minimal mitigation opening, are having a lot of cases. And unfortunately, a lot of schools are needing to close. Kids are having to go back to virtual and having a lot of kids quarantined. So if you have not opened yet, I would highly encourage schools to layer these mitigations, particularly with how much COVID we have spreading, to keep your kids in school safely, to keep businesses open, to keep hospitals open, so that we can be able to get through this current surge together as quickly as possible.
Thank you. And Dr. Shah, anything to add?
Nothing from me.
Great, thank you. Then let's, Dr. Shah, if we can start with you on that second question regarding to the extent that you can, any reaction to possible reported increase in healthcare-associated infections in your?
I am not at all surprised. We have seen this anecdotally. When you alter the standards of care, the precise preventive measures that you normally take are not as easy to maintain. If you consider the things that require to prevent, bloodstream infections because of intravenous lines, catheter infections from have indwelling, urine catheters, they require a high degree of attention and protocolization of activities. And when we stress the healthcare system, there are going to be bad, parallel outcomes. And it's not just around COVID. It's going to be healthcare-associated infections. I did help investigate an outbreak or increase in central line infections, and that's exactly what it was. It was an inability to follow the proper protocols because we have, in many ways, overwhelmed the healthcare system over and over again. Healthcare is an exhaustible resource, and we are sorely pushing its capacity to keep up with the quality of care that we expect.
Dr. Dobbs, thank you. Others?
The only thing that I would also add to that, I completely agree with everything Dr. Dobbs said, is that we know that just like our kids are human and they go to school, but they also are out of school, so are healthcare providers. And so we do see increasing infections in our healthcare providers now, but it may not be from the healthcare workforce. It may be from, when they were at a restaurant or they were at a kid's event. So what happens in our community affects what happens in our healthcare setting as well. And so we continue to see that impact the ability to provide healthcare across the state outside of just the increased infections as Dr. Dobbs had mentioned.
Thank you. Thank you. John.
Nothing further to add. I think Drs. Dobbs and Zink nailed it.
Great, thank you. So, Alan, next question, please.
All right, we'll take another question. Please go ahead. Your line is open.
Hi, this is Cheryl Stolberg from the New York Times. Thanks for doing this call. I was struck by Dr. Shah's assessment that the entire country is now a hot zone. And I wonder if the rest of you agree with that, and also if you can kind of put your current experience in context of the whole pandemic. The tone that I'm hearing from you reminds me of what we heard at the very outset of the pandemic, and I'm wondering if you think that things are as bad, worse, or maybe better now than they were then.
Cheryl, I'll kick it off and just provide some context, and I'm eager to hear my colleagues' reflections. The figure that I mentioned, 96.6% of all counties being in either high or substantial levels of transmission, that comes straight from the CDC. I fact-checked it last night. They may have updated it this morning, but that is, per their definitions of what constitutes substantial or high levels of transmission. And that is a significant increase just from the last time we convened this group 5 weeks ago. And that's the basis. I'm deeply concerned. There, of course, are some glimmers on the horizon that we may be nearing some sort of peak. I think it's too early to tell with any degree of certitude whether that's the case or not. And even to the extent it is, the UK saw something of that effect. And then, of course, after a slight diminution in cases, is now back on the upswing. So even if we are at some sort of nominal peak, it really may be a question of when we resurge again, not a matter of if. And so, the question for us here, at least in Maine, as well as my counterparts and I talk, is what are we doing now to steel ourselves against future such surges? What can we learn from these current experiences? And of course, what other tools and tactics can we use to get more folks vaccinated?
Thank you.
Yeah.
Others?
Yeah, this is Dr. Zink. I'm also a practicing emergency physician, and I would agree that this is, in some ways, the worst point in the pandemic from my perspective of where we've ever been. We had said from the very outset that what we were trying to do was flatten the curve, and that dotted line that we were trying to flatten underneath was the healthcare capacity and keep those cases underneath our healthcare capacity. But what we see across the country is that we are above that healthcare capacity. We are forcing clinicians to make impossible decisions right now on their ability to care patients. I am seeing crowdsourcing for beds thousands of miles away on Facebook groups of other emergency medicine physicians I'm seeing, trying to figure out how to hook up multiple vents or one vent for multiple patients. The choices that many practicing physicians are having to make on a daily basis right now across our country because of the lack of healthcare capacity in this entire surge of young, healthy people showing up in the emergency department sick with COVID-19 is heartbreaking. Our systems are completely overwhelmed in many places across this country. We saw this in isolated areas before. I mean, the devastation that we saw in New York was humbling and terrifying in so many ways. But there were nurses that we could call from other places who could go and respond. But at this point, people are exhausted. People have hit their limit, and the entire country is surging to one degree or another. And while different places have been hit at different times, and Mississippi has been hit so hard right now, and it's great to have Dr. Dobbs here, the stress across the system has expanded well beyond the South across the entire country. And our tools are really asking individual Americans to make the decision to get vaccinated, make the decision to not go to that gathering, to not travel, to not, go into that store or restaurant unmasked, because we really need to minimize the impact of never taking care of a patient in the emergency department who planned on having a heart attack that day or planned on having a car accident that day. Life happens, and we need to make sure our healthcare structure is set up and is prepared and is there to take care of the heart attack and the stroke and the car accident and the appendicitis and the COVID. And right now, that may not be the case in many places in this country because of how stretched the healthcare system is.
Yeah, and this is Thomas. I agree entirely. That the Delta surge was inevitable. The hospitalizations and the deaths was not. And if we look at what we're experiencing, yes, the whole country is seeing cases, but the whole country doesn't have to see the sort of degree of deaths and hospitalizations that we're witnessing. Some folks will say, what about Israel? They've done a good job with vaccinations, but they're still having cases. Yes, they are. But little Mississippi has more total cases and deaths than the whole country of Israel, right? The point of this is not to prevent every case, which would be laudable, but it's to save lives and keep people out of the hospital.
Thank you. Alan, next question.
All right, we'll go to our next caller. Please go ahead. Your line is open.
Hi, this is Carla Johnson from the Associated Press. Jim, if I could ask you to repeat the number you stated at the beginning about third shots to the immunocompromised since August 13th. And is there any way to distinguish whether that number includes some boosters being given off-label to people who are not immunocompromised? And then an unrelated question for Dr. Dobbs. I want to give you the opportunity to talk more about hospitals going into the crisis standard of care and really spell out what that means in terms of life and death for real people.
Sure. So the number is 996,000 third doses that have been administered since August 13th, and that was provided to us via a weekly briefing from CDC. Specific to your second part of the question, I do not have the level of detail to give you a sense of whether or not there are if that would be made up to anybody who would sort of be in that category of quote boosters. But that is it is showing up at the CDC data tracker as all third dose administration since August 13th. And Dr. Dobbs, I believe the last question was to you.
Yeah. So crisis standards of care. I mean, what does that mean? It means we're going to have to do things differently because we can't give people the full complement of services that we would want to. I think one of the easiest things to sort of identify is that intensive care room space and staff is so critically overburdened that in most places in the state of Mississippi, unless you're on life support, you're not an intensive care unit. We're managing people in spaces, in tent hospitals and other locations that normally, obviously we would normally have those folks in intensive care for monitoring in case they had trouble. We are not able to do the normal quality of care that we would want to because we are overburdened. We're having ICU rooms with 2 patients per room, not per ventilator, but per room. We're doing ICU care in the ER without the full complement of our intensive care resources. These are the things we're talking about right now. And, and there's 1,000 other smaller things that we don't do the way we would want to or have the sort of timeliness of response because we have, in fact, overburdened the healthcare system.
Thank you. Next question, Alan.
All right, we'll go to another caller. Please go ahead. Your line is open.
Hi, this is Lauren Gardner from Politico. Thanks for taking my question. This has kind of been referenced throughout the call, but I'm wondering if you could just put a finer point on the question of resources at state and local health departments to do all of these countless things, balancing boosters with convincing people to get their initial series of shots, dealing with the sheer number of people being hospitalized right now, and combine that with natural disasters leading people to need the healthcare system and cold weather coming. If things continue as they are right now, what can you just kind of describe what we should expect to see happen to the healthcare system across the country?
I can go ahead and start, and just I want to just make sure I'm answering or being responsive to your question. You're asking a systems question on the resources within the healthcare system, not so much the fiscal resources, just to make sure I'm getting that right.
Right.
Yep. So, here in Maine, I'll point to two things that we have zeroed in on in the past 2 weeks. We have right now 45 ICU beds that are available, that are staffed, and that number has fluctuated between as low as 39 last Friday up to about 65 earlier in the week as staffing patterns change. But we're at 45 right now, which is not the number I'd like us to be at. I'd like us to be higher. And in general terms, there are three things that make an ICU bed. There's the bed itself and the room to put it in. There are the sophisticated equipment to deliver high levels of high acuity care, ventilators, things like that. And then third, and really critically, staff. Right now, our limiting factor, our rate limiting step in Maine, and I think also in the Northeast, is staffing. It's been an insidious combination of staff, ICU qualified nurses being burned out and not wanting to work in the ICU, coupled with surging patient demand, and so just the need for more. That's one element, and it's one that I foresee being even more acute if this surge continues. The other thing that I'll note that we have been grappling with is another reason for hospitals being packed is, and this was referenced a moment ago, oftentimes when individuals are sick for COVID or non-COVID reasons, there's nowhere for them to go in a step down or discharge manner. Long-term care facilities or rehabilitation centers are booked. Or alternatively, they too are experiencing staffing challenges because of things like COVID. And so what's happening is patients are being stacked up in the hospital with nowhere to go, and that's exacerbating what's already a packed situation.
And I'll just add, on to what you said, Dr. Shah, that what you're going to see is you're going to see less healthcare workers who are willing to work in hospitals. I know in Mississippi, we've been informed that we're 2,000 nurses less than we were 7 months ago. And why is that? Because we've worn them out. We can only ask so much of folks before they decide either to take an easier position or to retire altogether. It's a lot easier to burn out a nurse than it is to create a new one.
Ms. Van Zink, I would echo everything that my colleagues say. I would also say that we're starting to see some increasing shortages of additional supplies, such as some medication that are really critical for the ICU and others. And we're starting to see increasing shortages on some testing supplies, so continuing to try to address those in as many ways as possible. And then I would just really emphasize Dr. Dobbs' point on the end. Our healthcare teams are exhausted. This has been incredibly hard. I was working with a nurse the other day, and he said, the moment we intubate a teenager for this, I'm out. I can't take this anymore. It oftentimes feels like there's a tale of two worlds, what's happening in the hospitals versus what's happening outside the hospitals. And what's happening in the hospitals is heartbreaking, and it is demoralizing, and it is incredibly frustrating. And you can do it for a while, particularly when the virus was new and there was so much that was unknown, and we did not have tools to be able to respond. To be at this point where we have tools and to see so many people choose not to use those tools, like vaccination, becomes increasingly just morally challenging and heartbreaking. And it feels futile in so many ways. And so for those reasons, I think we're seeing a lot of healthcare workers, for their own mental health and well-being, needing to choose a different profession at this time, which is exacerbating the crisis.
And sorry to chime in again, I know I do want to move on to the next question, but this is really critical, and I mentioned this in my top of the comments. These indirect effects are really going to start becoming more in focus. It's not so much the direct care of COVID, but the foregone care of individuals who maybe needed that hip replacement, to say nothing of cancer surgery and other such things. That's going to be coming closer into focus. What's kind of happening at a big picture is, I don't know how to frame this. There's two kinds of full hospitals. There's full and then there's full. Right now in Maine, the hospitals are full, meaning we can't do the care, the non-essential, non-COVID care. I'm sorry, I said non-essential. The essential non-COVID care. We can't quite do that at the rate that we want to. We're full in that respect. But what Dr. Dobbs is talking about is a completely different kind of full, which is the entire hospital being consumed by COVID. Neither is ideal, and what we may see in the future is the country going from Maine full to Mississippi full.
Thank you. Next question.
All right, we do have one more question left, so star one if you'd like to queue up. We'll go to our next caller. Please go ahead. Your line is open.
Hi, this is Dorothy Millsgrave with Inside Health Policy. Thank you for doing this call. Actually, I kind of want to jump off the last comment that one of the doctors had in terms of it's the indirect effects. I'm coming from the perspective of children were having less wellness visits. Pediatric hospitals are now seeing a surge for a mixture of cases, right? Mental health care, deferred care, and then I always forget what the last one is. But we're seeing that surge in what's happening with children. What are some of your concerns moving forward as kids move into schools and public spaces increasingly during COVID?
Who would like to go first?
I'll start since we've already seen it. I mean, I think there's a whole host of challenges. I mean, without a doubt, most kids will recover, well from COVID, although, some will have, long COVID, but at a smaller rate. And we'll have some deaths, and we've had 6 youth die in the state of Mississippi, 3 in the past month. But if we don't do it right, we're going to be even more disruptive because kids desperately need to get back to normal educational pathways. And by us not following the complementary approaches that allow in-person classroom edifying educational experiences, we're actually forcing the kids to go back into quarantine situations or where they have to do virtual or basically no education because we didn't do the full complement of preventive measures that we know can really work to keep kids safe but also in the classroom.
This is Dr. Zink. I would just add and chime into that one. This isn't about mandates or telling families or kids what they need to do or don't do. We do lots of things in schools with protocols to keep their kids safe. My child was in a science class the other day, and they, put on their goggles to prevent eye injury from paper airplanes. We have tools to keep our kids safer and to keep our families and communities safer. Being in school makes a huge difference in their ability to learn, to be able to socially connect, to be able to have parents be able to go to work. The teachers and school nurses have been asked to do so much in this space, and the more that we can support them to be able to have that in-person learning. But then again, I'm also reminded of the impact of, how many families have been impacted by their parents, their elders, their grandparents being sick and being impacted by COVID-19 as well. So I get asked a lot about how about the mental health of our children, and I think that is critically important that we continue to look at. But our mental health of our children will be best protected when we're able to keep them in school, learning with healthy, happy, and safe families. And to do that, we all need to work together to control COVID-19.
There are just 2 brief notes. This is Nirav that I'll make. I think the question is correct. And we have been focused on one particular element, which is recent legislation here in Maine that removed religious and philosophical exemptions to school immunization requirements. Actually just went into effect yesterday. And so we've been for weeks, months now, focused on getting kids as they go back into school back up to date on their childhood immunizations. That's critical, and as I think everyone on this call is aware, something that lagged a bit, particularly for adolescents during the pandemic. And then the other thing I'll note is a recent paper that I believe was in JAMA that noted relatively significant weight gain among kids. Again, care that's been delayed in this case was care denied for those kids, and query how often or how much more intervention they may have received and attention had they been going to those regularly scheduled pediatrician's visits.
Thank you all. Alan, any more questions?
And we did have one more queue up, so we'll go to that last caller. Please go ahead.
Hi, thank you for taking my question. This is Gary Burton with WJTV out of Jackson, Mississippi. And I know here in Mississippi, since school has started back, we've had cases that have significantly risen, as well as the number of shots and arms for the younger age group. So my question is there any indication or information that you can provide as to when or if we can expect the vaccine to be eligible for children younger than 12? And is it even safe for the younger age groups?
Thomas, happy to let you field that one if you want.
Well, you know, I know there's studies ongoing. There's not any reason to suspect that it would not be equally safe for younger children, but I don't have any sort of information on a date when that's, I mean, obviously we're hopeful, but I don't have any, good inside information to understand what that time frame might look like.
Excellent. This is Jim. Certainly that's a very solid, excellent question. But again, we are not in a position to, we are not the best body, if you will, to sort of give you a direct answer to that. But thank you for raising that anyway. Alan, anything else?
And yes, we did have one more queue up, so we'll take that last one. Caller, please go ahead. Your line is open.
Hey, it's Max again, just because it seemed like there was an opportunity for another question. I know folks in your position don't like to talk about yourselves, especially with such a holistic approach in trying to help the public. But, Dr. Dobbs, I know you had a couple tweets about this, but I'm just curious, especially as there's been a push to vaccinate, if you all both personally and also with maybe members of your staff or other heads of local health departments in your state have seen a rise in harassment or threats or misinformation about you personally as it pertains to trying to get people to be vaccinated. Thanks.
And this is Thomas. I'll just go ahead and answer real quickly. It's an unfortunate reality of our current sort of situation. Public health folks are highly committed, dedicated, and just trying to help people survive and thrive. And that's all we're here to do. I think on the positive side, we have had some, and I still get some, menacing things from time to time. But I will say that the vast majority and the overwhelming number of communications that I get are positive and supportive. And I think that that's the majority of Americans. And I think that we need to recognize the majority of Americans who, vaccinated or unvaccinated, who recognize the work that we're trying to do, and not let the sort of the more fringe conspiratorialists drive the conversation when most folks are very appreciative.
This is Nirav. I've seen some of that misinformation even being spread about me personally. I've told some of my team, if you look me up, if I look myself up online, I don't think I'd like what I found about myself either. But I try to keep in mind that much of this, I think a lot of this is driven by fear, and it's that fear that transmutes into anger. Folks are uncertain right now, and in the face of not just COVID, but as Jim mentioned at the top, everything else going on, it really does seem like the world is turned upside down and doesn't look like it's going to right-side itself for a while. And that's really scary. And I think in some precincts, that fear generates anger or manifests itself as anger. I try not to take it personally because I don't think it's intended personally. I think it's an expression of what is genuinely, in the minds of many people, complete uncertainty about what's happening.
This is Anne. I would echo what was being said about the just uncertainty and fear that's out there. I had a patient in the emergency department the other day, and he said, when you talk on the TV, I think that you're just part of a government conspiracy and I don't trust you, but you're actually a person and you're here. And I think that there's a lot of good reasons for mistrust about, everything from government to pharmaceuticals to systems as a whole. And I think it's very natural and human for people to have questions and doubts But at the end of the day, we are people, and we are, residents of the states that we serve in, and we do our best to be able to help to keep our neighbors and our friends and our communities safe and happy and healthy and thriving and moving forward. And so when someone's angry or upset, I just remind myself of how much mistrust and how much misinformation there's out there. It's incredibly confusing if you just try to go online and figure this out. And so continue to try to encourage people to come to trusted sources of information. If they have questions, talking to their primary care provider. Appreciate the media and others trying to get out the messages, because it's a confusing landmine of additional information out there. And so just try to take it with compassion.
Excellent. And certainly in my judgment, an excellent topic to close on, because it really surfaces the elements of civility, respect, and resilience, not only as professionals, but also as a community or society. So thank you for raising that question and placing it at such a sweet spot in our program today. So with that, our time together has come to an end. So allow me to close by doing a couple of things. First, again, to extend a very personal and direct voice of gratitude and appreciation for our three panelists, Doctors Shah, Zink, and Dobbs, for sharing with you their perspectives, their experiences, and providing you a very direct dose of reality of what a pivotal or critical juncture we are in this response going forward, and how essential and imperative all of the actions that we've talked about as far as prevention go, and not only for COVID, but also the other second order or indirect consequences that we've spoken about, especially in an environment where COVID is not the only thing that's threatening the health, safety, and well-being of our communities. We're keeping the public health and healthcare sectors very busy doing what they do best, and that is serving the public. A special thanks to our press corps who joined us today and for your questions. We certainly we always welcome this opportunity, look forward to it. I can assure you there will be future ones on the horizon. But meanwhile, if you do have any other follow-up questions or requests, you all sort of know the drill. Feel free to reach out to Jane Esworthy, who is our Senior Director of Public Relations, and Jane and her staff can be reached at media@astho.org. That's media@astho.org. So with that, I thank you all very much. Wish you a very peaceful and restful holiday season, a holiday weekend approaching. And as always, please be safe. Thank you very much, and please feel free to disconnect at this point in time.